All right, everyone. Good evening. I'd like to welcome everyone to tonight's MSIG webinar, where we're continuing the series on textbook injuries, where each speaker will share their experiences on specific sports and identify the most common injury or injuries from the sport. It's an honor to have the following AMSSM members serving as our four-member speaker panel. Dr. Joanne Allen will give a presentation on sailing. Dr. Kristine Karlson will give a presentation on rowing. Dr. Kelly Ryan will give a presentation on equestrian. And finally, Dr. James Eggert will give a presentation on rodeo. My name is Madeline Niblock, and I'm a third-year medical student at the Michigan State University College of Osteopathic Medicine, and I'll be serving as your moderator for tonight's webinar. After all of our speakers have shared their presentations, I will serve as the moderator for a Q&A with our speakers. During the webinar, please enter your questions in the chat, and I will read each question during our Q&A segment. Now, it's my pleasure to introduce Dr. Joanne Allen, who will make a presentation on sailing. Dr. Joanne Allen is an avid competitive sailor who is board certified in physical medicine and rehabilitation. She has practiced sports medicine for over 30 years and covered sports at all levels and in multiple sporting environments, including Olympics, Paralympics, WNBA, AVP, WTA, America's Cup, Volvo Ocean Race, and all things sailing. She currently serves as a physician for UNC Wilmington men's soccer and women's basketball teams and is chair of the U.S. Sailing Sports Medicine Committee. She has focused her sports medicine interests on injury prevention and sailing, and in her free time, she is usually on the water enjoying life. Dr. Allen, please begin your presentation when you're ready.
Thank you so much for the kind introduction. I'm going to get this. All right, very good. Well, I am an avid sailor, and I appreciate the opportunity to speak on the sport of sailing, and it has been my love and passion, although I've been very active in other sports too, but it's my favorite. And I live in North Carolina at Wrightsville Beach, and I'm very fortunate to be able to get on the water pretty regularly. So I wanted to have a little disclosure. I don't have any financial relationships to be discussed, but my real disclosure is I race Lightnings. Those are the sailboats you see right there in the photo. It's a three-person boat with a spinnaker, a main, and a jib, and I trim that beautiful Duke Blue spinnaker. So that's what I usually fly and do tactics. So we race out here very regularly. So I wanted to start just kind of with a little question, like how did I get so lucky and how did we all get so lucky doing sports medicine and working as team physicians in sports that we love? I think all of us have been honored to have been encouraged to follow our dreams, and I'm definitely grateful to all those who have impacted my younger years as an athlete and my medical career as a team physician. So before we do anything, I think we all have to say thank you to our parents, teachers, coaches, teammates, classmates, attendings, colleagues, mentors, and lifelong friends. And AMSSM is one of those main reasons that we all have these lifelong physician friends that share our love for sports medicine. So thank you, Joan, again. So I'll just say a little bit about myself. I went to Duke undergraduate, Wake Forest Medical School, UAB for residency, did a fellowship at the American Sports Medicine Institute, and I've always been a part of AMSSM, ACSM, AAPMNR, and U.S. Sailing. So those have gotten me along as it goes. So sailing's actually been a vital mode of transportation and trade since the dawn of history. The Phoenicians and Egyptians and Romans had early boats, and the first vase painting with a sailboat on it dates back to 3200 BC. As far as we know, no one started yacht racing until the mid-1600s when Catherine had a gift to King Charles and Anne for the king's brother, and that was the first racing yacht, was Catherine. And so the races started then, and they've never stopped, but they've changed a lot. The history of sailing, the types of boats, the competition is ongoing and evolving every year, every day. So as a team physician, we're all responsible for making medical decisions regarding the health and wellness of the team. And that really is going to vary depending on who we take care of. I was very fortunate to start my career with 1996 Olympics and Paralympics in Atlanta. And I worked both in Savannah and Atlanta. And really had a great experience. So I was fortunate to start then and lucky enough to meet Muhammad Ali too. So I love that photo. I had to share it. Of course, the role of the team physician is care of the athlete, doing pre-participation exams, medical history, and you don't think about sailing necessarily as always a super competitive sport, but it is dangerous because seizure disorders, for instance, cause a 15-fold increase in drowning risk. You can have pulmonary issues and concussion issues too. So we want to make sure that we know the medical history of our patients, prior or current injuries and illnesses, medications, allergies, etc. And of course, we want to consider nutrition and hydration issues, REDS, all of our female athletes, depending on whether there are weight limits in the crew, that can certainly be an issue, whether it's that or sports psych or training and fitness and performance measures and the biomechanics. We have to use all our allied health providers and athletes and coaches as part of our game. So in order to really take care of a sport like this, you have to learn about the sport and that covering the athletes, that what their needs are. Sailboat racing involves really a lot of different types of boats and events. And so the top picture, for instance, is the Lightnings that I race, but now everyone's on hydrofoils and, up off the water foiling. And this has increased the speeds and the risk because of that. So everything changes a good bit. But most people are familiar with the America's Cup because it's televised regularly and it's the oldest competitive race in the world. It uses now high performance foiling at extreme speeds. They use AC75s and AC40s, that's the length of them. And this causes the athletes to be a bit of a higher risk due to higher energy and trauma with collisions and capsizes. So it's sort of a new frontier for sports medicine compared to when we started. So you have to address safety measures more. How do you prevent the injuries? Because as you see in these photos, everyone's up on foils, but if you capsize, everyone's barely hanging on, and it can be very risky and dangerous. So it's been real interesting to watch how this has changed really even over the last 20 years, where we've gone from monohull boats to these high performance hydrofoiling rigs. And now we're even monitoring performance and work power and heart rate, etc., on the boat and recording that live as they're pedaling to try to increase the speed and change the tack and the edge of the sail. So that's been really interesting to watch the monitoring. So I started working with my America's Cup women's team and injury data collection back in 2000, actually in 95 with the women's team, and then in 2000 and 2003 over in New Zealand. And we started collecting all the data from all of the different teams, which was a really unique opportunity because now they really don't want to share that information with anybody. But back then, they let us all collect it, and we all kind of came together as athletic trainers and physicians to try to gather the information so we could better help our athletes. So that's been a real interesting opportunity that I've continued to kind of try to use. The Women's America's Cup now has started again in foiling boats as a separate event almost. And again, injury prevention is a little different with them depending on their crew size and the boat size. And we still have to consider things like weight management and those issues. So there have been monohull data that has still, again, noted that the upper extremity overuse injuries are usually greater, followed by lumbar spine. Some of that data has been published back, like I said, back to 2000 when we started. And now that they're foiling catamarans, the traumatic injuries are growing, and we're collecting all that data. That started in 2016. And that's for the America's Cup, but there's a lot of other different types of sailboat racing. So these photos are from the ocean race, which used to be called the Volvo Around the World Ocean Race. This was from 2022, 2023. These are raced in two different types of boats. They're high performance foiling, and they are extremely competitive, challenging conditions. They go all the way around the world. And there are definitely times when it is just unbelievable water conditions. So Charlie Enright in your bottom left corner, he actually won this past year. He's an American, and it was fabulous listening to him talk about the challenges they had, including sleep deprivation, nutrition. We always train a medic on each boat, so they have that, and we have contact directly with a hospital through sat links. But there are injuries. There was a clavicle fracture on his boat after they hit a whale off the southern coast. So there, those kind of things that happen, and you have to be prepared. In the past, we've had people that have had, emergency abdominal issues, etc. So it's a very interesting race. So again, you have to know your races, your playing field. What type of body of water? Is it in the open ocean? Is it on a river? What are the waves and the wind and the temperature like? Are we just doing a short course around the buoys race, or are we doing distance races? Are they teams? Are they solo? Are they able-bodied or disabled? So, is it an Olympic race, a national regatta, or are you looking at a local event? So paying attention to exactly what you're trying to cover and the athletes that you're taking care of is important, that you know these issues in the sport. So every time there's a regatta, there's a notice of race and a SI sailing instructions, and those should include a medical plan and an emergency action plan, including the access point as to where you're going to deliver someone who has a problem. And the float plan that needs to be discussed details more of the safety boat logistics. And if you're covering as a physician, if you're helping cover an event, you need to be working with the safety officers in order to really work with risk reduction, and especially when it's getting at higher speeds. And it's really important to also know and pay attention to the chain of command, the chief safety officer who's going to coordinate emergency plans and the support boat duties and lifeguards and rescue swimmers. So this, for instance, was one of our world championships in the Lightning, and the waves and wind were huge, and they got dismasted, meaning the mast of the boat fell off. And one of them fell in, and they had to have a rescue swimmer come in, and that's the safety boat in the background. So, but this was all well coordinated and managed well, and everyone did okay. But it's just important, if you're going to cover an event, to know all these things. And we even practice capsizing. We don't like it, but you sometimes are better off trying to practice it, just to make sure that you understand safety-wise how to get your boat back up, because it's not easy in these boats. We have had episodes of mortality. Unfortunately, one of the Great Britain sailors drowned in the 2016 America's Cup. He was also a British Olympic medalist, and he just got trapped up under the rig. And so those things do happen. So obviously, attention to safety, and not only safety, but then teamwork, and then attention to the biomechanics and the physical demands of each crew position really help you kind of try to prevent injuries and take care of the athletes. So let's talk about epidemiology a little bit. The overall injury rates are anywhere from 0.29 to 4.61 per 1,000 days of sailing. It's a little bit middle of the road there in the America's Cup, 2.2 to 8.6, so a little bit higher. The mortality is actually similar to American football as far as U.S. Coast Guard data says from a drowning perspective. So it's not always as safe as you think sailing might be. It's not the champagne drinking sport. Most common injuries are actually sprains and strains due to overuse. We do get traumatic lacerations. We certainly get concussions, but a lot of these vary with crew positions. So, for instance, in this photo, the helmsman, the person driving the boat, may get more of an issue with a carpal tunnel, whereas the grinder over here in the front on the winch, he is actually grinding a lot, and they get grinder's elbow, which is similar to a tennis elbow. The dinghy classes, like the lasers here, usually have a pretty high VO2 max, because they are really having to pump and hike out as they're going up and down the wind. And they also have a lot of biomechanical leverage that they have to use on their knees, with a lot of torque on both the knee and the lumbar spine. And these things can induce knee pain. And really, technique is very important when you're sailing a laser and racing this competitively. So improper technique can really increase some knee pain at time. It can also cause other issues. So this is a case study, for instance, a 16-year-old U.S. Sailing Development Team sailor is constantly hiking in upwind breeze a lot. As you can see, when you're hiking out, you're leaning way out of the boat. And he had quite a bit of low back pain ongoing despite his rest and rehab, but of course he ended up having a little pars injury in his back. So we shut him down for a little bit, but then let him race in a brace, and then he ended up doing fine and returning. He ended up racing in college and at a very high level on the national team. But that's a typical laser-related injury. Here's another one, a college laser sailor, same thing, low back pain. Thinking it might be the same kind of thing, a pars defect, but no, he actually had a disc herniation. And then, it becomes an issue of, well, he wants to sail in the national championship right before Thanksgiving. This was just this past Thanksgiving. And, it's a matter of, do we let him return to play? Does he want an epidural before that or no? Do we want to brace him? Do we want to change anything in his technique before a national competition? Not really. So that became quite a bit of management issues. But these are the types of cases that we'll see. There's a lot of data that's been collected a little bit more in the foilers over the last couple of years. So Ben Tan did a World Sailing Federation championship race analysis in 2014, and the 49er and the RSX and the NACRA are all the foiling higher speed boats, and that's where most of the injuries were. A lot of, again, lumbar spine, knee, and shoulder. Also, occasional illnesses, of course. I'm still on the injury part, though. Helming the foiling boats in high speeds, the physical stress, like I said, of the dynamic hiking, whether it's on a laser or if you're on a trapeze hiking out with a line holding you up, or managing the foiling systems, or pumping the sails when you're trying to balance on a foiling board on a kite. Those are all pretty high physical demands, as are trimming the sails on these large coffee grinders on bigger boats, the explosive, powerful maneuvers you have to do those during tacking or jibing, and managing spinnaker systems. Those are all pretty high physical demands, not to mention some of the mental demands of the navigators and the tacticians. So, as you can see, these incidences of injury are definitely directly related to some of the physical demands in the crew positions. Another one, looking at a foiling regatta. Again, a lot of our data is increasing in the foiling regattas right now because these are the newest boats and events that are occurring in our games and just with a lot of the younger sailors. So we're still getting quite a bit of musculoskeletal injuries, upper limbs and lumbar spine, again, acutely involved increasingly. So as we understand a little bit more about the physical demands, the crew positions, and the maneuvers, trying to address proper form, for instance, the neutral foot position hiking out, or really using your lower legs when you're trying to grind on one of the big winches, and making sure you have good proper gloves and anti-skid surface on your boats. That's helpful. Making sure we have safety at sea issues covered, such as tethers and life jackets if you're out in the big ocean. Always wanting to wear life jackets if at all possible. Proper clothing, protective gear, and sunscreen. Sailing gloves, again, proper hand positions on the lines. We have multiple histories of people losing their fingers because the finger gets, kind of latched into the line as it goes around the winch. So we have to be really careful with those hand positions on the lines and keeping them tidy. So as our athletes come to us for advice on what do we do to prevent injuries, we want to address all of those things, but also look at what they're doing in the gym, improving their strength and endurance to reduce fatigue-based injuries, and address their cardio because it is often a very aerobic sport, and depending on the boat class and the crew position. And of course, the hydration and nutrition and recovery issues are there, nutrition and weight issues. Some boat classes do have weight limits, and there are weight cutting issues, just like in wrestling and other ones. And it's actually a current issue right now in some of our kite classes because the more you weigh, the better you're going to, faster speeds you're going to be able to go at. So we're trying to address those things in regards and with the information, trying to prevent REDs or any other ongoing issues with that. Again, the sports psychology is certainly always important, especially in sailing with tactics and navigation and smaller teams and crew work needed. We do have illness issues, of course, as we travel or go on these long regattas, whether it's paying attention to illness prevention, just with, trying to avoid sharing water bottles, or seasickness prevention, or aquatic life exposure. Of course, we have that as another issue, a large jellyfish that, sometimes will show up in different environments. If you're in China or Brazil, the things that are a little different in other countries with marine life that we have to pay attention to. Hypothermia, heat illness, and we do have ice boating. So the ice boatings have different types of collisions. There speeds exceeding 60 miles an hour, and we have to have rescue gear and ice picks. And I try to avoid those personally as a good Southern girl, but they are people out there covering those events. We have fantastic Paralympic and disabled and para classes. These were the sonars that we got a bronze medal for down in Rio. And one of our 2.4 meter sailors from Norway down in the bottom photo. And they're all different types of classes now that we're sailing in the parasailing worlds. So as we go through, I want to finish up. We are addressing concussions. Certainly more and more people are wearing helmets to protect their heads as we're getting faster speeds on our boats. It's never too early to start educating the youth in our high school programs. And so we do try to start working with them early and get them to pay attention to the hydration issues. This young man, I started helping when he was 8, and now he's sailing for the UNCW team. And it's kind of nice to see him grow up and learn from what I could teach him possibly and others. There's a lot of information out there. I hope that you all will read it if you're interested. I will say that you have to be prepared for change. This is Betsy Allison, who's a 5-time Olympic Yachtswoman of the Year and was our Paralympic coach for 20 years and just raced her own Olympic campaigns, and she suddenly became injured and became eligible for parasailing and is on lost strand crutches, as you can see. And I went over to a world championship last year with her, where her first time back in a boat, and she won the world championship, got her gold medal. So that was really fun to be with her there, but we had always traveled together as coach and team physician, and it was a little different this time. But always be prepared for those winds of change. So as extreme sailing gets out there, you're going to have more speeds, higher speeds, higher risks, foiling, and just like they did in Paris, and we'll hopefully have in LA. And I know our thoughts go out to all of those in the Los Angeles area with the fires, and hope we'll be back together with all of them during the games in 28. And thank you so much. Just remember, we can't direct the wind, but we can adjust the sails. Thank you for your time.
Fantastic. Thank you, Dr. Allen, for your excellent presentation. Now, it's my pleasure to introduce Dr. Kristine A. Karlson, who will be making a presentation on rowing. Dr. Kristine Karlson found rowing as an undergrad at Williams, having never seen a rowing shell or been on a sports team. As a medical student, she continued to see success in rowing. Attendees will find out how much success, and this led her to sports medicine being a natural choice. Dr. Karlson has continued to travel with the U.S. rowing team as team physician for 25 plus years. And now, Dr. Karlson, you have the floor.
So I start here with a career moment that I was asked to do at a Dartmouth medical school talk. So my career moment starts with family medicine, sports medicine in my 3rd year. I liked everything, didn't know what I should do. And but wait, I discovered as a medical student that I had a certain talent for rowing, and started to think in the direction of being an Olympic athlete. And so I spread my medical school over 5 years. I spread my intern year over 2 years. And I ended up 5th in the 1992 Olympics in the quad, which is a boat of 4 people, each person with 2 oars. I retired from rowing and finished my residency because at that point I had a continuity requirement, and I had to go back and live a normal life. But they added an event to the Olympic program that I had previously won a gold medal in. So I tried out for the team again and earned a trip home. So I did not make it to the second Olympics. So then I did a sports medicine fellowship, and I've been at my current job since 1997. So I have half medicine, family medicine, and half non-surgical orthopedics, and I'm a Dartmouth team physician. I also got to return to the Olympic Games as a team physician in 2008. I continue to travel with USA Rowing, and I've been back to some of the venues where I competed, which is kind of cool. So I'm going to talk about rowing. And instead of previous talk, I'm going to talk specifically about one injury, which is rib stress fractures, and a little bit more general about chest wall pain, because this is really something very specific to rowing. And I think if you've never taken care of rowers, you may never have heard of a rib stress fracture. So just to review the rowing stroke, on the top left is, this is actually an Olympic silver medalist who is a sports medicine physician coming out of emergency medicine, who has just started her medical career, having retired from Olympic rowing. Jevi in this top picture is at what's called the catch, where her arms are extended, legs are all folded up. And then the top right, this is called the drive. She's using her legs and then her back and then her arms. And I would direct you to look at her arm in the foreground. And I probably can't show you my pointer, but in the foreground, there is a connection between the shoulder and the rib cage that needs to be thought about. This is called the finish on the bottom left. And she's extracting the oars from the water, and then going back to the beginning is called the recovery. Chest wall pain in rowers can be a stress fracture. It can be a pre-stress fracture. This is sort of a non-specific pain that often gets ignored and say, oh, you know, it's just, you just pulled a muscle. And unfortunately, some of those end up going to stress fracture. I'm also going to talk a little bit about muscular injuries, so-called costochondritis, and the slipping or snapping rib syndrome. So start with rib stress fractures. Like any stress fracture, this is of insidious onset. That is, the pain, when you think about it in retrospect, has been there for quite some time and escalating, but there often is one final day where the athlete says, I don't think I can do this. Typically, this is in situations of higher volume or intensity of training, which is similar to stress fractures in virtually any other bone. It's often in an athlete who is new to the program. We're still working on the exact etiology. The load that the athlete gets in the stroke, there's been issues with oar design. The more efficient the oar captures the water, the more force is directed through the hands to the arms, to the chest wall, to the back, to the hips, to the knees, to the feet. The serratus anterior is an important connection between the shoulder and the chest wall. And then there's also breathing that sort of has to happen while you're rowing, and that's going to expand and contract the chest wall. So all of these things are potential contributors. In evaluating this, you can ask about the so-called load. The load an athlete will know about if they are on the rowing machine, the rowing ergometer. They will also report if they have been rowing by pairs in the 8. So this is a drill that some coaches want them to do, which is if only 2 people out of 8 are rowing, you can imagine that the load per stroke is pretty high. And this is a drill that I try to discourage coaches from doing. A so-called low stroke rate with high force is going to be a problem. In their history, they will also tell you they have pain with coughing, sneezing, laughing, rolling over in bed, reaching with their arms, and even running could hurt because of the arm motion. On physical exam, this starts with a sort of generalized pain, and then they will end up being able to point to one spot on one rib. Usually it's the lateral ribs 5 through 9. It can be reproduced with a rib compression away from the pain. I tell athletes, I'm going to give you a little CPR now, and let's see if that hurts you in your other spot, as in if I'm pushing in an AP direction and they hurt in their lateral rib, I just bent the rib and I caused pain at the site of the rib stress fracture. So that's a useful physical exam test. Back in the day, we used to use bone scan, and I've been showing this picture for years because bone scan shows this problem really, really nicely. As you can see, there's one rib spot that lights up. We don't use bone scan much anymore because it takes about 4 hours between the injection of radioactive material and the scanning. We use MRI. You have to ask and make sure that the radiologist knows that you're looking for a rib stress fracture, because they're going to have to do cuts that are a little different than another chest MRI, because otherwise you could miss this if you're knowing that the rib goes higher in the back and lower in the front. Depending on their cuts, they could miss this if they're not doing enough cuts. You can, if you have the skills, ultrasound this and see a rib stress fracture on ultrasound. That is not a skill that I have, but others younger than me have been developing that skill. So I expect that medical students will all have that skill, or at least when they finish their residency. Management of this depends on what season you're in. In the winter, our rowing athletes are able to cross-train. A lot of them cross-train on a stationary bike, which works out really well for the rib because they're not really pulling on anything. It takes up to 4 to 6 weeks. So if I have an athlete right now at Dartmouth who has chest wall pain, I would say, okay, great, let's put you on the bike. Let's do most of your work on the bike, and you should be ready for spring season. If this is late in their spring season, which is a major competitive season for collegiate rowing, I might say, let's do whatever we can to try to work on treating your pain. You'll try to row if you're able. And I may not even get any imaging on that person or the person in the middle of the winter. If a clinical decision needs to be made about can this person continue rowing, that's the person that I will get imaging on. I will recommend that they try to decrease the load per stroke if at all able. Non-specific chest wall pain I want to talk about because this probably is a pre-stress fracture. It's just like medial tibial stress syndrome or shin splints in the shin that if you continue to ignore the pain could lead to a stress fracture of the tibia. So a short time off of rowing or cross training may pay off if they catch it early enough. And they're highly motivated not to report this, but I really try to stress that this would be great if they could report early because their time off may be significantly shorter. Just to illustrate where the serratus anterior is and how it sort of interdigitates with the external oblique, you can have pain in the serratus anterior. You can have pain at the medial border of the scapula or its insertion on the ribs. If serratus isn't working right, someone trying to do a push-up against the wall may have winging of the scapula. Intercostal muscles, people sort of poke at their intercostals and go, yeah, I don't think it's a rib, I think it's intercostal. Like I say here, you have to put that on a stress fracture continuum because it's probably going to evolve into a rib stress fracture. Costochondritis, I like to tell athletes and show them pictures that the chest wall is not entirely rib, that the front of the chest wall is cartilage, even though it feels like it's bone. And some rowers, when they are there at the finish, will actually hit themselves in the chest, and they could be causing costochondritis. The location of this pain is right at the costochondral juncture. It's similar to stress fracture pain, but it's too far anterior, and it's at that costochondral juncture. This is tough to get better because we have two tissues that have to get along, which is what I say to athletes. This is the bone and the cartilage have to figure it out and decide to get along again. And these are harder to get better because of that. So I don't really have a, yeah, your bone is going to take 4 to 6 weeks to heal. Bone cartilage interface, I'm not sure how long that's going to take. Kind of like a tendonitis. The so-called slipping or snapping rib syndrome needs mention. This is instability of the 11th floating rib. The 11th and 12th rib do not connect in the front like all the rest of the ribs. Rib number 11 that ends in the sort of anterolateral chest wall can slip underneath the 10th rib. They will have pain at the lowest margin of their chest ribs. There may be a clicking or popping sensation with each stroke, and I've actually had this in field hockey players as well. Field hockey, everyone has to shoot right and they have to lean over. Everyone has the same length stick, so some tall people have to lean over more, and they can get that 11th rib stuck under the 10th. Local anesthetic injection could help to confirm the diagnosis, and I've had a hard time trying to find surgeons willing to remove part of the rib, but I have had several cases who have gone on to a partial rib resection. And I believe that's all I have.
Thank you, Dr. Karlson, for your outstanding presentation. Now, it's my pleasure to introduce Dr. Kelly Ryan, who will be making a presentation on equestrian. Dr. Kelly Ryan is the current president of the Maryland Academy of Family Physicians and a faculty member for the Department of Medicine at MedStar Franklin Square Medical Center. She works in the Department of Orthopedics, specializing in sports medicine, and is the medical director of the MedStar Health Concussion Clinic. Dr. Ryan serves as a team physician for Towson University and the Baltimore Orioles, as well as the medical director for the Horsemen's Health Program at Maryland Racetrack and the Baltimore Running Festival. She is dedicated to providing exceptional care in both family and sports medicine while advancing medical education and community health initiatives. And now, Dr. Ryan, please proceed with your presentation.
Perfect. Wonderful. Thank you so much, AMSSM, for inviting me. I think anytime that an organization, such as AMSSM invites you to speak on your particular topic, it's definitely quite an honor, particularly for the people who taught me so much that I know. My story is a little bit unique. I am not a horse person. I am not an equestrian person myself. Prior to starting this particular job, I would say that I probably am now. Although I've only been on a horse maybe 3 times. I think that they're terrifying, and I'll show you some of the reasons why I can believe that they can be so dangerous, although they keep me having a job. So I'm grateful for that. Although, I was young and hungry, finished my family medicine residency, did my fellowship, ready to get into sports. And this is what they had to offer me to stay with my organization, MedStar Health, which is a wonderful organization for sports medicine. So I would do anything that I had to get my foot in the door. I actually had to Google equestrian medicine to even figure out like what kind of injuries. I hadn't really heard about much from equestrian injuries or anything like that. So I started Googling, and I found I actually found a reality TV show called Jockeys, which is where I learned a lot about my athletes. And now that I've been there for almost 10 years, I feel like I really understand them. And I think it's really important to listen to your athletes, listen to, what their goals are, what their challenges are. And sometimes we think that we know best, and we really don't. And that's why talking to your athletes is so important. And this is definitely one of the fields that I've learned that from. They are some of the toughest athletes that I've ever taken care of. I would have put them up against any football player, any lacrosse player, even though they're, very small in stature and weight. They are very mighty and are really tough. So there's a couple different forms of equestrian. I particularly take care of what's called flat racing, which is, when you ride on the horse, riding around the track, and usually in flat. But there are people who are crazy enough to jump over objects while on horses, jump off of objects on horses, dressage and polo, fox hunting, rodeo. There's some rodeo equestrian that we'll be hearing about later tonight. I'm from Maryland, so we have kind of a really big event every year, and this year, surprisingly enough, is our 150th Preakness Stakes. It is a second jewel of the Triple Crown, and I've been fortunate enough to attend that multiple times. It's a great event. People get excited about horse racing, and so that's one of my favorite days of the year. This is just a quick video of them coming out of the gate. So you can see that they, they take off at speeds at about 40 miles an hour. And, pretty much anything can happen on any given day at the racetrack. I'm not sure if everyone else always goes to their job thinking like, I wonder if I wear the same socks, if like this is going to potentially put me at risk for a bad injury today at the track, or, you never, I just kind of always, try to think positive when I go to the track. But again, knowing that any given thing could happen on any given day, and whether or not we're going to have an AMBO coming to the track that day, and if I'm going to be sending one of my athletes out or not. So the sport, particularly for horse racing, it's one of the most popular sports worldwide. There is flat racing, and there's also steeplechase, like I mentioned, where they jump over things. The jockeys sit on top of the horse, and they call that a martini glass position. The way that they sit, there's a couple different riding styles depending on where they come from, whether it's, in over in the UK or whether it's here in the United States. Sometimes even different states have a little bit of different riding techniques. Generally it's 5 to 12 furlongs, and the racing can be between anywhere between like 30 and 40 miles an hour. So they're when they fall really hard and they fall really fast. There's anywhere between like 4 and maybe 20 horses in a race, and some tracks will typically race 9 to 14 races a day. There's also multiple tracks that race at different times. So some of my jockeys will actually race 2 different racetracks on the same day. I have heard of someone doing 3, and it is $1 billion industry, although unfortunately there's not really that much money in it in terms of jockey health and medical care at the racetracks. They typically weigh less than 120 pounds. This picture is very unique because at that time we had the most female jockeys that we've ever had. Every once in a while we might have 2 or 3 in our jockey colony. Our jockey colony typically consists of maybe about 30 riders at any given time, like for a day of racing. But at this particular time, we had a huge outshowing of women. So that was really a fun time. Like I said, sometimes they'll race 1 to 10 races a day. Sometimes they'll actually leave from one track and go to another. A lot of them have to be careful about what they eat. They often starve themselves or won't eat until later in the day. They actually wake up in the morning and will be at the racetrack at about 5:30 to train some of the horses. It's in the morning. That's kind of like when the horses get their exercise. It's really interesting how we train horses versus how people train, like our runners. The horses don't train every single day to run. Sometimes they're just breezing. Sometimes they're breezing, which is a higher speed, but sometimes they're just walking and just, more casual type of speed. So they're not necessarily running all the time, but they do utilize the jockeys for those higher speed because they can handle it. They typically don't do weightlifting or strength training because they're concerned about gaining weight, although the ones that are really good understand that there is benefit to that. We're trying to change that, change that thought process. They have some pretty bizarre weight loss practices. They wrap themselves in cellophane sometimes. There's, oils that are used. There's hot boxes, which are essentially like saunas. You can lose like 1 to 2 pounds in half an hour in the hot box. They sometimes will bike on an exercise bike that's next to the hot box, so they still get that. Sometimes they'll sit in their cars in their sauna suits and turn on the heat really high. They're constantly traveling, so their sleep is pretty disordered. And then they'll be racing. They train in the morning and then they race in the afternoons or evenings. So again, they'll sometimes take naps throughout the day, but a very disordered sleep. The other player is, essentially the horse is a pretty important part of horse racing, obviously. It's almost like they're running on their fingers, and to learn and talk to the vets at the racetrack is pretty interesting to hear about what kind of injuries they have. Essentially, if the horses are not sound or in good shape, that typically affects our athletes. They will exercise about a mile a day. They usually, if they race, they don't race again until about 3 weeks. So they're not racing constantly like our runners might. They have a lot of personality, and sometimes it's just interesting to hear, the jockeys really have quite a connection with the horses, and they tell me that they have different personalities, kind of similar, like people have different personalities. You cannot race a horse until they're 2, and that's because of their bone structure and things like that, and because of the stress, because horses can get stress fractures, and that's typically when they have injuries. The Triple Crown horses are only allowed to race at 3 years of age, which a lot of people just didn't know. The track is made up of dirt. Sometimes it's made of synthetic materials or turf. The time of the year that they race really depends on where you are, because if it's too cold, then the turf will freeze, and that affects the stress on the horse's bones, and so then obviously affects our jockeys as well. So we want to make sure that it's nice and sound, and they actually have people who specialize in just track management for these types of things, and there's degrees out there in Kentucky and such to learn how to take care of it. And then different tracks use different, again, types of dirt surfaces. Steeplechase has different types of jumps. And then you also have to be concerned. Some bad things can happen in the barn areas when there's a lot of horses and a lot of people. The paddock areas where the horses get saddled. And that can also be a really dangerous area because you have a horse in a very small area with lots of people who are trying to get the saddle on it. And then the gate area can also be an area that we have concern. Different medical considerations that we think about for jockeys. We're really trying to work on their nutrition. They're just not supposed, the size of these humans are not really supposed to be 118 pounds. And unfortunately, the times have changed with weights in general, and they haven't really changed with the weight allowance for jockeys. The horses carry, larger humans in the morning for the exercise riders aren't all as thin as the jockeys, so they train that way. But people are still convinced that an extra 2 pounds of allowance for a jockey is going to make a huge difference. And so it's really challenging for them to maintain that for so long. It can affect their performance. And then also, we have to consider their bone health, make sure that they're, taking vitamin D if needed. They do have a lot of rapid weight loss, which can cause some problems in terms of their health. There's this condition called flipping where they actually will it's self-induced vomiting, which is kind of just a normal thing in the jockey's room, to help them to get down to their weight that they need to. Sometimes they'll be using diuretics. Unfortunately, it's not very well managed. And, obviously there's a lot of Lasix around the racetrack for the horses. There's been times that I've heard that, jockeys will take that as well. Other diuretics, and there's nobody who's really monitoring that or keeping them from doing such things. They don't really have, they will sometimes test for alcohol, and they will test for, for narcotics and oxycodone and Adderall occasionally, or stimulants or something like that. But it's still not very well regulated in the United States, to be honest with you, and it's really sad. Something that we're really trying to work on. From a psychosocial standpoint, a lot of them have had some terrible injuries and keep coming back. I have one jockey who had 27 fractures by the time that he was 27 years old. And, that can be a lot of bone pain. Just their stance that they have on the horses can kind of put them, in an uncomfortable position. And then a lot of them they'll finish racing and then they'll go and drink alcohol and then have to lose all that weight in the morning. It's just really a challenging way to live. And then all those orthopedic injuries are certainly a consideration. The talk here today, we kind of talked about, what's one of the most common injuries that you have in your particular sport. Well, I would say that the most interesting thing about jockeys is that you have like a million case studies. I've had 2 occipital condyle fractures in 1 year, which is just really fascinating. I've had an esophageal perforation. I've had 2 liver lacerations. I've had a radial collateral ligament tear. And so, there's no loss of, poster presentations for AMSSM every year from these different injuries that the jockeys have. So really the most common injury in a jockey is whatever happens when they fall and hit the ground. They're so tough that they rarely ever even talk about any of their chronic problems, unless it's just a continuous, injury that they've had. But they rarely come in to see me for that type of stuff. They're just really tough, and they want to race and they want to ride. So some key takeaways is that jockeys face some really unique injury patterns. Prompt diagnosis is super important, and balancing early return to ride with minimalizing refracture risk is really important. This will just give you a quick inside look of like, so this is inside the gate. They're on the horse. There's actually someone else who's in the gate with them. This is also one of the most common places for injuries, either before the gate, in the gate, or leaving the gate. The horses are a little bit unruly, particularly the thoroughbreds. But you'll see them take off. They're very close together. You don't really have a lot of room for making any type of errors. You can see how right now they're just kind of hanging out. That is, like I said, called the martini glass position. And then as they get closer to, to the finish line, they'll kind of like crouch down a little bit more. They have to balance on these irons. Only the front part of their foot is on the iron to balance themselves, and so that can be really challenging. Oh, sorry. Okay, there we go. So and one of the things that we really are trying to improve at our particular racetrack is concussion management and those types of things, because if someone has a concussion and they want to lie through their teeth or fake their exam, if they are able to even do that, and they want to go back out and get hit in the head again, that's one thing. But the problem with horse racing is that if you get on a horse and your balance is off and your depth perception is off from a concussion, you risk putting other people at risk of getting injured. And unfortunately, sometimes they can actually be fatal. One of the most common injuries that we do have, though, this is a case that I came up with. 32-year-old professional jockey falls from a horse during a race, high impact on the left shoulder, and he ended up being transported to the trauma center. X-ray showed clavicle fracture, no neurovascular compromise, and CT showed no additional chest or thoracic injuries, and was a mid-shaft clavicle fracture. Clavicle fractures are very common just based off of how the jockeys get tossed and land on their shoulder. We were able to put together this paper about injuries that we found in our Maryland jockeys, and this kind of like lays it out based off of where most of the injuries happen. Like I was saying, was either like prior to the gate, getting into the gate, or leaving the gate. The other area that has a lot of high risk for injuries is this home stretch, where they're really racing at the highest speeds, and the horse is kind of like at the end of their race. And then it kind of is really evenly distributed. We have head injuries, shoulder injuries. Also, if they get pinned in the gate, sometimes some leg injuries. I have had an ACL tear before. Communication during these emergencies is super important, because seconds could really matter whether or not it's life or death. And unfortunately, there's been a handful of times that I can remember putting a jockey in a ambo that I wasn't sure whether or not they were going to survive. Jockeys do die on the racetracks every single year, unfortunately, and equestrian injuries are very common and very dangerous. One of the things about this is, though, when we're talking about emergency management and looking at, trauma cases and things like that, just by mechanism of injury, almost every single case could essentially go to a trauma center, because they're racing at such high speeds. They have high falls with direct impact. For the differential diagnosis for a clavicle fracture, the other things that we think about is there's a lot of rotator cuff injuries. I've had some dislocations, sternal fractures, had one of those. Glenohumeral dislocation. And then one of the other really interesting cases that I've seen before was actually a sternoclavicular dislocation. Typically, they are anterior, except for if you're falling off of a horse, there's certainly the risk of having a posterior dislocation. You can treat this either surgical or non-surgical. Of course, it depends on, what the gap is, and those types of, whether it's not its comminuted, which often it is. And, if they need surgery, I have had jockeys who have come back to riding in just 6 weeks, which is pretty phenomenal. The thing that you have to think about is if they come back, technically, is horse riding considered a contact sport or non-contact? Well, contact would be with the ground, and anytime you're on a horse, it could, throw you off and you could hit that ground. So there's certainly that concern about if they were to fall again. Yes, their strength is okay, but if they fall again, is it going to just refracture? And so we always have to have shared decision making with them, and think about some delayed healing or complications, or also especially because a lot of them do have poor bone health. So just kind of depending on how they're going to do. This is an x-ray of I actually had a posterior dislocation of the sternoclavicular joint on one of my jockeys from landing directly on his shoulder. And you can actually, this is not a great image, but you can see here, and it actually was pushing up against the brachial artery, and he was fortunate enough to be okay and ended up having surgery and is back to riding. This isn't necessarily him, but here's just another example of what happens when you fall off of a horse and get trampled. The one thing that we do have in sports medicine at the track, which is really nice, is if we have a jockey who has an injury, we can actually put him on what's called an equicizer and kind of stimulate riding without actually putting him on a horse to make sure that they can maintain their stance, make sure that they have good shoulder strength, or particularly for a concussion. This is part of our return to a ride protocol. So I'd like to just thanks AMSSM, and a special thanks to my jockeys for everything that they've taught me. And if anybody out there has any racetracks near you, we are looking for more doctors to get involved. Please reach out to me.
Thank you, Dr. Ryan, for your excellent presentation. Now, it's my pleasure to introduce James Eggert, who will make a presentation on rodeo. Dr. Eggert is on faculty and serves in the role of Associate Program Director at the University of Wyoming Family Medicine Residency Program at Cheyenne. Dr. Eggert holds an undergraduate degree in bioengineering from the University of California, San Diego, and graduated with honors from the dual language program at San Juan Bautista School of Medicine in Puerto Rico. Dr. Eggert is an active member of the American Medical Society for Sports Medicine, overseeing the resident team physician involvement for the University of Wyoming Athletics and Cowboy Medics program at Cheyenne Frontier Days Rodeo, Professional Bull Riders PBR, and POCUS MSK curriculum. Prior to medical school, Dr. Eggert trained under Dr. Calvin Wong, primary care physician for the San Diego Chargers. Outside of medicine, Dr. Eggert loves the water and is an avid freediver and scuba master diver, and enjoys mountain activities, including backpacking and skiing. Dr. Eggert, you can proceed whenever you're ready with your presentation.
Thank you very much. I appreciate the invitation. Okay, we're going to get this started here. On your end, are you seeing my presentation deck or the presentation slides?
We can see your full presentation. We're seeing what you intend us to see.
Excellent. Well, thank you very much for the introduction, Madeline. I appreciate it. Thank you to my colleagues for sharing this space and opportunity with me. Tonight, I'm going to be talking about textbook injuries for rodeo medicine. My name is Dr. Eggert. I serve in Cheyenne for our family medicine residency program. So I'm going to give the perspective of what we expect medical students to graduate into when they come for residency, and then what we train them for when they're going to go on to fellowship. So that'll be my approach tonight. Financial disclosures, I have none to disclose. How I got involved with the rodeo. So Cheyenne Frontier Days is a historical landmark in the history of rodeo. Rodeo dates back to the 1500s in Mexico and came to the United States somewhere around the 1880s. There's debate about which was the first rodeo, but by the end of the 1880s, it was in several places. Cheyenne Frontier Days opened in 1897 and has run continuously since then. This year, we'll be celebrating our 129th consecutive year. We have residents who participate in our rodeo activities. We partner with our local law enforcement, our first responders, firemen, our military response in the community, EMTs, paramedics, and our local trauma services. This year, we had 8 of our residents and our clinical pharmacist, who's there in the center, it's Dr. Salama, and then 8 of our residents who are there. They provide coverage for our athletes and the animal athletes, the people that support them, and some of our crowd folks. So from a family medicine perspective, what is required by the ACGME? The ACGME has loosened this up quite a bit. It's now just a structured sports medicine experience. So the opportunity is broad, and we kind of define that the way that we want to. We do it by approaching rodeo from a position of biomechanics. Injuries are broad. You've heard about some of them in the equestrian presentation. Thank you, Dr. Ryan. Things that we see often are concussion and crush injuries. We've got large animals are moving at fast speeds. Athletes and the trainers often get underneath the animals. And then we work on back and neck, as you can imagine, is pretty common with the crush. The 6 major joints being shoulder, elbow, wrist, hip, knee, ankle, foot, and then overuse injuries from each one of these techniques. Residents are expected to be able to manage the initial evaluation and management of those injuries. We also provide care for spectator injuries. So that includes heat exposure, heat illness, stroke, dehydration, sunburns. A few years ago, we actually had a case of heartbreak syndrome, Takotsubo, that was diagnosed on a bedside echo that we had, and then was taken to the hospital, made a full recovery, but kind of keeping the differential broad for our spectator injuries. Residents are also expected to be able to manage appropriate imaging and referrals. We have quite a few specialists on board with us. We bring CT surgery in, we bring ER, general surgery, and then some other community providers are dentists and optometrists to help us with face injuries as well. We have X-ray on site, we have ultrasound on site, and residents are expected to appropriately coordinate with those other specialists for the management of our athletes. So what are residents expected to have with them? Our airway kit is fairly robust. We've got full EMS. We've got an ambulance on our side dedicated for our work area. There's also community ambulances that are out and about, but there's one designated just for us for transporting athletes if they do go through a crush or other major event. They've got bag mask and ambi suction if they need it. Residents are carrying stethoscopes, pneumodarts. Our CT surgeon has a chest tube tray that residents can participate in if they need to get into the chest. And then they've got tourniquets in their pockets, and they've taken Stop the Bleed courses. Some of them have become Stop the Bleed instructors. Simple things we get a lot out here are going to be bee stings, EpiPens, Benadryl, famotidine, Zofran, those types of medications to manage an acute allergic reaction. And then asthma, albuterol. We've got breathing treatments with Duonebs on the bus in case we need it. If a simple albuterol treatment doesn't help. As I mentioned, we have an ultrasound device. So being able to perform a good fast exam in the field, we've been able to diagnose pneumothorax out there. We've had rib fractures out there. They've been able to identify those on ultrasound. And then one of the favorite tools that the residents like to use are our Raptor shears. If you can cut a Kevlar vest off, just like football pads or anything else, if you can get to them, be able to place pads, begin compressions, getting that gear off of them quickly is really important. All right, single most common injury. This was up for debate. We have several. It hasn't been talked about extensively tonight, so I was happy to hear that. I'm going to go with the GH joint. So glenohumeral joint is the most common to dislocate. In the general population, it's probably 11 per 100,000 with an incidence or prevalence of about 2 to 8% in the general population. First time dislocations are typically anterior traumatic dislocations, which is what you can imagine happens in rodeo. Those are typically in an abducted and externally rotated position. So if you were to imagine, if you've never thought about being on a bull before, but imagine what it would be like if you were in that place, reach down and grab on and kind of imagine what it would take to hold yourself in place. That's going to be your most typical abducted and externally rotated position. Takeaways, when we're thinking about how to manage these in the field, we're thinking about, do we want to try to set it? Do we want to take it back? Do they want to have surgery? Do we want to immobilize it? There are things you want to think about when you're considering how you want to manage these injuries. What is the history? Is it the first time? Does a surgical evaluation and treatment pattern versus immobilization change our outcome as far as osteoarthritis goes? Are there effects of delaying surgery? And what would we call the correct way to immobilize? There have been some papers, there have been some reviews, some things that we can kind of pull out as common things we'll talk about. Individuals younger than 25 years old are likely to redislocate with non-operative management. I have an orthopedic surgeon who's a mentor of mine, and he will describe the shoulder girdle just like you would describe a concussion. If it comes out, goes back in, and it happens repeatedly, you can have laxity that is progressive, and the quicker we go back to injury and delay long rest, the faster and more severe the return rebound injury will occur. So if it goes out once, gets back in, we give it time, may do well. If we get out once, go back in, and then return right to the sport, it'd be just like a graded return to play a concussion. We need to give more time in the shoulder. I think personally that's where I fall. I don't think there's broad data that says this is the absolute correct way, but it would seem appropriate to me. Other things to think about: if we go to surgery, it reduces the risk of recurrent instability. Patients with recurrent instability do appear to be at a higher risk of osteoarthritis. And then some discussion about external rotation braces, whether those are most effective. The piece that I would ask medical students to consider is defining the best timing and type of treatment is a challenge. And we got to tailor that to the arena that we're sitting in. And so what are the types of things we want to be able to do to make that decision when we're in the field? So one, the initial, when you walk up to them, we're looking for things like hemorrhage. Are there any signs of open fracture? Are there any signs of arterial injury, which we're going to assess with distal pulses? If you're absent on your pulses, definitely attempt a field reduction. Reassess those pulses after you're done, and then transport. And then nerve, sensation, motion, the types of things we train in our neuro exams should be considered as well. And then how do we approach this in the field? There are several recovery techniques. The one that I'd probably highlight, you could go Google, YouTube, practice at home, is going to be the Boss-Halzak Mater maneuver. That's a self-reduction technique. It's the one that's listed in the top left of my photos. You can place arms around a knee and then give yourself traction. If you're able to reset it that way, you may not need a second person. Others, like the Cunningham technique, will require a second person. If you want to partner up with another person in your medical class, you guys can practice those. Other techniques that can be used are Stimson, which is gradual weight, scapular manipulation, and then traction, counter traction. I'm a big guy, 6'5", pretty hefty. Two of us sometimes can't get an arm back in. You may require some sedation. Most of the times in the field, especially with rodeo athletes, you'll be able to put the arm back in. Big thing to remember once you're done, please remember this, this acronym of FACTS, which is, do they have function? Do they have adequate arterial supply with good capillary refill? Is temperature appropriate and sensation appropriate? You know that you've put it back in the right place and they're working the way that they should. All right, so field reductions, good things about them. They improve comfort. There's a higher success rate, decreased cost. If we go into the facility, you may need to, if there's a contraindication like swelling or fracture. There may be a legal component. Where are you reducing this? Are you set up to be there? Do you have coverage to be there? If you are concerned about success, if you don't think you can do it on your own, if you haven't done one before, you may need to give it one try, especially if there's a lack of a pulse. Give it a good try. If you can't put it back in, don't waste time. Get them to the designated or final facility where they need to be to get definitive care. And then if you have a case that's a likelihood of a poor outcome, something like a pediatric patient, geriatric patient, diabetic, someone post-seizure, please consider taking them to the facility. They might need further work. So if I was a medical student and I was asking, how can I prepare at this point? Things that we talk about a lot in rodeo medicine and anticipation is going to be an MCI. Mass casualty event is any incident where the number of patients exceeds the amount of healthcare resources available. So for us, the big ones we talk about are going to be things like lightning strikes, hailstorms, and tornadoes. We're an open arena of 20,000 people. We have hail every year. We have lightning every year. It is possible that that could be a mass casualty event. There's other things that we talk about, you know, national crisis moments, shooters, those types of things. And so we go through what is an appropriate management strategy. For us, our EAP includes that all of our providers are going to shelter until the scene is safe. And then we go through different approaches. There's a SALT triage, there's a START triage, there's a 10-second triage. This is to help you come up with a plan. Who is an appropriate patient to manage? Who is an appropriate patient to leave behind? Who is an appropriate patient to redirect? And being able to work with your local event to create an EAP or an emergency action plan that works for you is very important. And be sure and practice these things with others so that when it comes time, it's something that you have and you're ready for. But for our events, it's going to be shelter in place, find safety. Once they go out, they know how to do the triage assessment, and they're going to wait for the support group to come in. And we have a plan as far as whole city, hospital group, and then the arena, who's going to be prioritized for EMS. The other thing that you can do as a medical student is go ahead and enroll in a Stop the Bleed course. This doesn't take very long. It's very simple, but there are techniques here, how to apply a tourniquet, how to stop a bleed with a single finger, how to look for injuries, and then how to report them and get people stabilized is really good. And then the third thing I would say, if you're a medical student, resident, even a fellow, if you didn't go to an area that's rural or emphasizes emergency care, is how to manage the following case. So I'm going to play a video now. This is an injury that occurred this year at rodeo. And what I'm going to ask you to do is, if you're a little bit squeamish, maybe look away. We're going to play it once through. I'm going to play it in full speed, and then I'm going to play it a second time, watch, and I'm going to comment on how it was managed. So here's our video up from this year. All right, we're going to go the second time. Give you a break. I want you to watch how fast it occurs. The athlete is up. They are engaged. And once they're struck, once they take the hoof to the face, they are out and become a defenseless athlete. I just want you to watch how everyone else responds once that occurs. So things I think are excellent here, and you think about the defenseless athlete, they're going from full speed to no speed, is you got the bullfighter who's coming up right at the head of the athlete, protecting the head of the athlete, making sure that no one comes back to him to be able to direct the animal away. The biggest injury concern from my perspective when you have a downed athlete is that the animal could come back and create a secondary injury, injure the people who are coming in to respond. So scene safety is going to be big here. And then secondary, what I would say is if you can go through your ATLS training and think through your ABCs, you need to have an airway, you need to have an idea about bleeding and then circulation. So if this is a guy who's going to be GCS less of 8, how am I going to get a definitive airway? What is that going to look like? What is my transport going to look like? As a resident, as a fellow, I think those are things that we can think about and anticipate and then work in our EAPs to be able to create a safe environment. This athlete was transported, was hospitalized and released. They've publicly shared how their hospital course went. You can go and look that up if you'd like to, but for the sake of the learning, getting to the athlete, protecting them, and then getting them to definitive care is going to be our goal. All right, thank you very much.
Thank you, Dr. Eggert, for your outstanding presentation. Before moving forward to our Q&A segment, I'd like to express our gratitude to our speaker panel for their amazing presentations and for sharing part of their evening with the resident and student members attending tonight's webinar. I'll now serve as the webinar for our Q&A session. So anybody that has a question, feel free to enter in the chat. All right, so we have one here. During boating, do you see a lot of exposure injury such as hypothermia?
Yes, we actually do see some hyperthermia and hypothermia for that matter, but we do get some hyperthermia. Really, particularly in some of the regattas where you're on the water all day, there'll be 8 hours of being on the water out sailing and sometimes directly, in the sun with really no opportunity to shade. And we really try to keep everyone hydrated, but even our opti little kid sailors, they're out there sometimes longer than we would like. So we do try to pay attention to it, but it certainly happens, and we do need to stay aware of that and take care of our issues with that.
Fantastic. The next one I think is probably for you, Dr. Eggert. Which of the rodeo events has the most common injuries?
Great question. So, great question. Okay, so catastrophic injuries, we've probably had the most in an event called the Wild Horse Race. So the Wild Horse Race traditionally has been unridden horses. Now it's unbroken horses. They come into the arena. There are teams of 3. One is supposed to hold the horse down. The other one's supposed to control the horse. They're supposed to get a saddle on. And then the riders hop on and they're supposed to do a run around the arena. That starts with a gunshot. So all the horses start kicking and bucking right out of the gate. And I have had a single injury that was a subdural hematoma, an intraparenchymal bleed, C-spine fractures and T-spine fractures. That patient was hospitalized several months and then in rehab for almost a year. So catastrophic injuries, it's probably that one. As far as our acute injuries for the professional bull riders or professional athletes, either saddle bronc, bareback, or bull riding, just because the animal size is so great and the fight is so high. If they get underneath them, I've seen horses come up and headbutt against helmets, and then once they go under, they get trampled on, and that's typically where we worry the most. One big advance from a death in the arena that happened back in the 1980s is they do wear vests now that are Kevlar front and back, and so we can cut in on the sides, but it gives them the protection from the crush. If the bull does come down and put the weight on in a single hoof, the vest will take the majority of that and hopefully save the ribs.
Right. Well, I will start wrapping things up. If something else comes in, I'll be sure to tend to that before we end the meeting. But before we conclude tonight's webinar, I want to encourage you to join us for the next webinar hosted by the AMSSM SMRC on carving your sports medicine career next week on Tuesday, January 21st at 8:30 p.m. Eastern Time, featuring a 7-member speaker panel sharing about their clinical practice. Dr. Irfan Asif will share about his academic/research practice. Dr. Griffin Albert will share about his community practice. Dr. Jason Matuska will share about his private practice. Dr. James Miller will share about his rural practice. Dr. Nicholas Hitamia will share about serving as a sports medicine fellowship director. Dr. Brett Torsado will share about serving as a team physician in his clinical practice. And Dr. Nahil Coleman will share about integrating telemedicine in her clinical practice. You won't want to miss hearing about their insights and advice. Looks like people are just saying thank you in the chat, no new questions. So with that, it has been my pleasure serving as the moderator, and I'd also like to thank everyone attending tonight's webinar. And once again, thank you so much to our speakers. And this concludes our webinar. Thank you, everyone.
Thank you.
Alan.
Thank
Thank
y'all.
you.